Great. Thanks for the paper link.
You're welcome.
So welcome everyone to Neuroccino on this Monday morning. Very briefly, the rules of the game is that anyone is welcome to come and join us to present a paper they thought was exciting. Just come on and tell us why you think it was an exciting paper and what you got from it. Briefly present it, and then we discuss it to the best of our knowledge. Now, today we have Anne-Katrine Oehlert. She is a postdoc here at the Max Planck Institute in Nijmegen, and she has a very exciting review paper for us on the localization patterns of speech and language errors during awake brain surgery. Annie, if you want to take it away.
Yes. I'll, of course, take a second to share my screen that you should all see now.
Perfect.
I'm minimizing you as a group so I can see, the majority of the screen. So yeah, good morning, everybody, and thanks for having me, so to say. I am myself coming from a background of stimulation mapping. I work with NTMS. Maybe that's a paper for the future to present. But this paper I chose today is on intraoperative mapping. So it's called DES, Direct Electrical Stimulation Mapping. And why I chose this is kind of the mother of the stimulation mapping. This is what it all started with. It's used mostly in neurosurgery these days because it's a very invasive technology and method that you only do if you really have to. So you have a patient with a tumor and you hope to localize functional boundaries around the tumor as much as possible in order to know where to stop resection and not to harm, in our case, the language system. So as I said, very invasive. And as well, the most direct tool we have to probe function and to test the brain. It comes with its own disadvantages as well. I'll come to that later. But the general idea is you open the skull, you have a so-called craniotomy. The cortex is then fully exposed, and you can then place this electrical stimulation on a small cortical or subcortical area later, once maybe some of the cortex is removed. And this stimulation can then disturb the ongoing neural activity in the patient that we have awoken at that point of the operation. So we have an awake and alert patient who's taking out a task. We're probing the brain and disturbing an ongoing activity we assume to have in this area. And if the patient can then not take out a specific task anymore, we assume to have found an area that's crucial for that task, and we're then sparing it. And that is this way of localizing function, in our case, language. And you can then, of course, pool all of these errors together, speech and language errors, and then, try to read from this pattern what it tells us about the functional circuits of the brain. The paper I'm presenting here is a very recent one. So it's a systematic review, just came out in January. And why I thought it's maybe crucial and interesting for this group as well is that usually when you have these papers, you're dealing with a really small sample size. The hospital that I used to work in, we had maybe up to 10 patients a year, usually much less, fewer cases, particularly the ones that are well enough to enter the OR and being tested. However, here they're putting together in total 102 studies. And all the patients there, all the error patterns they found, and then they're trying to come up with a location to function pattern. This is a group from Rotterdam around Gina Sautour. They're publishing a lot on this. One of their biggest achievement, so to say, is the DuLIP, that is the Dutch Linguistic Intraoperative Protocol. If you're interested in that, it's this whole paper on its own. I'll come to it in a little bit, but it is a guideline that is used across the Netherlands to guide intraoperative task selection. Now, coming to the actual paper here. The introduction just lays out why we're doing this kind of mapping, as I just summarized it. That, of course, we can encounter when we do this different types of speech and language errors. So when you have somebody take out a language task, most often that is object naming. So you see the picture of an apple. By stimulating, you can then break down the language function at different stages. So you could have the case that the person cannot at all name the picture anymore. It's called a speech arrest. So no language, no understandable language output. There could be phonemic paraphasia. So you might lose, that's about here. You might substitute some of the single sounds. You might come up with an altogether wrong word. So instead of having to say cat, you say dog. And all of these help us to pinpoint where in the language, in the cascade that we're assuming, or where in the language process the error happened, and what we're assuming then this area could have as a subfunction. Most often, as I said, object naming being used, but in theory, you could let the person take out any task. That could range from counting the days of the week to sentence completion tasks or narrating a story that you give them. Yeah, and preferably while you're facing a certain area, that you then choose the task accordingly. So for the IFOF, you might choose a task that's tapping mostly into semantics, such as sentence completion. Yeah, their goals were to, first of all, review what kind of errors they encountered in all of these different papers they're pulling together. Then where these errors happened, of course, and then compare it to the famous dual stream model for language processing. So how do these errors fit into that, as well as how does it fit to their own DuLIP model? I wouldn't even call it a model, to this guideline they came up with nearly 10 years ago now, which function is most likely localized where and how to choose a task accordingly. It's a classical review that was pre-registered, following the PRISMA guidelines. And mostly they were interested how many patients were in these studies, what tumor grade they have. This is important because there are some less and some more aggressive tumors, low grade being the ones that spread very slowly and gradually, and therefore there's more plasticity effects happening. Whereas higher grade tumors, they are much more aggressive, and there's less function relocation happening. Of course, now they wanted to count the speech and language errors and where they happened. And they also divided it into left hemisphere tumors, right hemisphere, and a bit of both. This is the breakdown, how they started from around 2,000 studies, nailing it down to 102. I think that's still quite a nice number. Of course, some of them might still be from different, from the same group. They tried to eliminate the ones where it was easy to pinpoint that it was even the same patients they were talking about. Yeah, I already shortly mentioned that there are different types of errors you can then look into. If you're interested in that, there's lots of papers, mostly going back also to the Corina papers, and yeah, some from about 10, 20 years ago, where we think that the different errors can now tell us where the language breakdown happened. So from speech arrest, the most critical error, to the more subtle ones or writing errors, they also came across the paper. Yeah, and the linguistic levels they point towards. As for the analysis, as they pointed out in the goals of the paper, just to see how many errors there were, which kind, and then also make a division between, was it a cortical or a subcortical area where this happened. One other important thing to point out is that they used the so-called DKT atlas. To me, unfamiliar, maybe to some of you more so. The full name, it's called the Desikan-Kiliani-Turville atlas. I'm not sure I'm butchering this entirely, but this seems to be an R package that they used in order to parcellate the errors coming from the different papers. With one of the shortcomings, how it's grouping together quite a lot of areas into the precentral gyrus. I think on the following page, there's how that looks like. but pretty straightforward analysis of counting errors and then displaying them as how high an error amount is compared to the overall errors. This is one of the things that for me could be done a bit differently if we had the entire data. So now we're saying of all the errors we see, this is the percentage that happened, for instance, here in the rather big precentral gyrus area that they delineated. Whereas in other techniques, we might be able to say of all the stimulations we did, this is the amount of error that we get in this area. For me, that's more informative because here, of course, we're just making an assumption of all the things we see compared to the other areas rather than, okay, here we didn't find anything. But this is one of the shortcomings and one of the things that happens with such an invasive procedure where you cannot test maybe the entire cortex as you would like to. The analysis, that's it for it. This is one of the more crucial figures showing that if we take the entire data, the panel in A, that's the pattern where we have the highest percentage of errors showing up in the precentral gyrus, also the STG. And that's very similar to these, what I alluded to earlier, the low-grade gliomas, so the less aggressive tumor types in B on the left. Whereas if we have in C, the higher the aggressive tumors, you see a very, different pattern from that. So we're assuming that these might have to be treated as a different group. There were fewer cases, as you can see here, only 120. I still think that's a really big number. So I would take this as a proper hint that high-grade cases display a much more effects of neuroplasticity that we can see when it comes to just the raw quantity of errors where they're happening in these cases. Then they looked at these error types. They came across a lot of the very bigger categories of speech rests. Anomias are the ones where you cannot name the target word, but maybe in the entire speech process is okay, but language-wise, you might not be able to come up with the target of the sentence. A few of the fine-grained areas, and now what I think is interesting in total, they encountered around 60% on the cortex and 40% on the subcortex. The subcortex here being combining both wide matter tracts and also subcortical structures beneath. They list the different tracks where the errors were found, the majority happening on the IFOV. I'm not going to go into detail when it comes to all of them. There's a figure summarizing that for those of you who are interested. For each of the error types, they came up with their own figure regarding left hemisphere cases, right hemisphere, and if there's a mixture of a tumor happening. Reading errors, for instance, seem to be nearly exclusively happening in the temporal lobe. You have usually very few morphosyntactic, so those are grammatic errors, and they seem to be only happening in the left hemisphere. So as you can see here in number 7, altogether an enumeration of the different error types. They did the same as well for the subcortex, separate figure, once more showing of the entire errors that happened on, for instance, the IFOV. How high was the percentage then of semantic, which was here around 70. I would go into the discussion now, however. Let me skip to see in my notes if there was anything else I wanted to mention. They do point out that this is the first extensive systematic review. I was also very happy to see that somebody had pooled together all of this, because otherwise it always seems rather anecdotal, lots of single cases we otherwise see with this method. They pointed out that overall the highest amount of errors are happening in the precentral gyrus, and those were the speech arrest errors, dysarthria, so unclear speech towards speech and motor problems and anomias. But once more pointing out that this is also due because the method they used collapsed a lot of areas into this precentral gyrus. Subcortically, the highest amount happened during stimulation of the IFOF. As I pointed out before, they want to make sure that we distinguish low grade, so less aggressive versus more aggressive tumors, which clinically is very important, that you don't assume they behave similarly. Yeah, sorry for that. Once more pointing out neuroplasticity. And as for one of their later aims, that was to compare the error types and the overall patterns to the dual stream model, that falls really nicely into the literature. So if we have our typical dorsal and ventral stream, the dorsal stream supposedly mapping sound to articulation, so phonological processing. Sometimes you can see this in intraoperative data, either if you use a task that specifically tests this. So preferably you would have something like repetition and that would break down, but also you can read that from the errors, for instance, in object naming, if you have phonemic errors, and their findings nicely fall in line with that, finding lots of phonemic errors on the endpoint of the AF. And in parallel to that, in the ventral pathway, supposedly taking out sound to meaning, so semantic processing. They found lots of semantic errors, as I pointed out before, comprehension errors. For me, that's a bit too broad of a category, but they allocate them as well to the STG, MTG, ITG. So overall, they conclude that it is in line with the dual stream model. Particularly the semantic errors on the simulation of the IFOF. As a last step, shortly mentioning that, how does this all relate to their own DuLIP model? I'll show you a figure for that in a second, that they came up with about 10 years ago, and now this is, so to say, an update paper on this. They first pointed out all the error patterns that did confirm their own little model. And I'm not going to spend too much time on that. I'll show you what it looks like. But more specifically, they did, an update on it. So this is what their model here in table 2, what they suggested. It's broken down into a lot of different regions and functions, pointing out one, for instance, here the first one, the IFG, that you should preferably test articulatory processing here and syntax as a function, and then also pointing towards the task in their own protocol that would help you test this particular level. This is what that looked like, written. I wouldn't call it a whole model because it doesn't really tell you how the areas interact. For me, it's more an enumeration of this is a function we assume, and this is the task you can use. But it's consisted of, this depiction of it. There's one for the subcortex as well. But with their newest, the evidence they have now from this systematic review, they would like to amend the following things. That is adding the postcentral gyrus to articulatory processing and motor speech due to the errors they found now. As well as adding MTG and ITG as a critical role in reading. The superior parietal and they do the same for the subcortical tracks, where the similarities, so where the current data fits into their model, says that, okay, of course, we're testing semantics on the IFOF, phonemic processes on the AF, reading in the ILF, spontaneous speech, also speech initiation on the frontostriatal tract. But to amend to that, here's the subcortical model they're suggesting, is to further split up the SLF and the AF. For some of you, this might not be very surprising that you shouldn't pull them together, but this is what came out of the current data. So emphasizing to take these two apart and split up their functions. Then to add the FUT for motor speech, Back then, I think the FUD was not as big of a topic as it is nowadays. So this is an amendment there, as well as testing phonology on the ILF, for me, the most surprising one. Similarly, for the uncinate fascicle. So due to, from my point of view, of course, a very low amount of errors. It's also one of my critiques for later. They have a rather arbitrary cutoff from my point of view, where they say, okay, this amount of errors, now let's us conclude that we think this task also belongs to the tract and is therefore worth testing in the OR. So the ILF for phonological processing as well, and the same for the UF. They point out once more that this is important for being used in the clinic. And as a last point, they do stress once more the importance of subcortical mapping. Just because we only saw 40% of errors happening here is really highly due to the fact that a lot of clinics do not even test the subcortex. The cortex itself is mapped out. Then it's assumed that we have localized language enough to assume the tracks underneath, and then the resection is taken out while the patient still uses spontaneous speech. So they're testing spontaneous speech in a way, but they're not probing anymore. They're just, once they see deterioration of the spontaneous speech of the patient, they might stop cutting. But this is how far the subcortical testing goes. So they wanted to once more stress that this is a bit of a skewed picture just because of how little is tested on the subcortex. So I would close with that and my few critiques that from my point of view, this is very interesting data, a technique that is very widely used and very crucially used, and big decisions are made based on this data. But of course, from my point of view, it's very important to keep in mind that we'll only find what we're testing for with this method. We're not testing every function on every location. So we're assuming already a function here. The test is then chosen based on this, and then we see a breakdown of language due to this, a priori choice of a task. The second critique, as I said, they're not pulling together all the stimulation sites and then tell you the amount of errors happening there, but they're just comparing all the errors that happened of a certain category to the overall error count. Still, it's a pattern from my point of view worth reporting on. It's a very different technique, and I think complements well other mapping methods. But of course, it's important to keep the disadvantages in mind. That's it from my side.
Amazing. Thank you so much. Are there any questions? Can't actually see you anymore. No questions for now. Okay, I have tons of questions for you. So you're absolutely right that we should separate the SLF and the arcuate. Is not anything new, even though we still see this a lot in the literature that is that they're grouped together. Mainly the differentiation is in the name, right? The arcuate fasciculus means arching, so it's arching around the sylvian fissure, frontotemporal, and the SLF is the superior longitudinal, so it's a straight association pathway, which is frontoparietal. And we know that they do have different functions. The only connection between them is the SLF3, which is the lowest of the three branches of the SLF, and the anterior segment of the arcuate, the frontoparietal indirect branch or horizontal, whatever you want to call it. So that differentiation is definitely not surprising. And I think it's good that evidence is showing it. Personally, I'm still puzzled by two things. So number one is the uncinate. It came up as phonological here, if I don't mistake that. Half the literature says it's semantic, half the literature says it's either not involved or does something else. So this in itself still puzzles me. And then that picture is perfect right now, the IVOF. So the IFOF in semantics, if we look at the connection, it's a frontal-occipital connection. How that is a primary connection for semantics, if you don't use a visual task, still puzzles me a little bit and comes down, and I know there's no surgeon here in the room, but I wonder if we do subcortical stimulations, if we're actually stimulating the right connection. So that's my 5 cents, but I see there's a question now by Sabrina, so I'll hand over.
I can quickly add to that from my point of view. Something I forgot to mention earlier, there are advanced techniques now that try to compensate for all the shift we're assuming due to the tumor. Of course, there's a lots of imaging beforehand, but also in the OR, once it's open, once some of the pressure is gone, we can then pinpoint where we now found an error and then later compare, but there's no really exact method to also know in the OR, are we really where we're assuming to be? So this is another factor. And when it comes to the visual task, object naming is the one that most of this data stems from. I would say 90% of the data. So there, that visual component is always present and you cannot further disentangle it. But I fully agree. If we had more tasks that left out the visual part, how much would the AF still show up so that we could still call it this really big term semantic?
But then even if you can pinpoint it afterwards by bringing all the imaging modalities back together, the IFOF is one of the longest tracks, right? It goes all the way from the front all the way to the back. And obviously along its course, it's mingling and like kissing and touching other connections. So even when you can pinpoint it, I'm not entirely convinced just yet that we are actually picking up the right connection.
Yeah.
And I might be wrong. It's just conceptually, I struggle with that association. Sabrina.
Yeah. Well, thank you for this presentation. But I'm wondering, do we have any specification about the task? So, I mean, how they analyze the different language processes. I don't know if there is a table, something like this, where they write and tell us what is in specific the task.
So I don't have the number in mind. Let me check if there was a table also pointing out all the variety of tasks, because here what they point out is, and I would have also liked more information on that, that it was purely the type of error. But a semantic error in one task, of course, looks different from a semantic error in another one, just by the length, the effort that might have gone into the tasks to end up at this. And there is not a very in-depth breakdown, apart from the fact how much of this data stems from object naming. So this one task that is really applied in 90% of centers without further specifying it. To be honest, I don't think, no, this is just an overview of the tumor types, but I don't think it's broken down further when it comes to, no, this was figure 1. So there is supplementary material. I would have to look into that to see, maybe it's describing it a bit more, but I was also lacking that because it's a good point to go from the error type, but you're losing a lot of information about the specification of a task.
A lot of questions now, Evie.
Yeah, because at the end is useful also for better understand also the brain part. But yeah, thank you very much.
Hi, yeah, thank you for the presentation. So I'm just trying to figure out the paper. So maybe it's a stupid question, but I was wondering for the region. So they give the percentage of error per regions, but I was wondering if it would be useful to have also the variability of these errors, saying that maybe in some regions there is more variability in the errors you can find because this region is not always at the same location, or it can be variable based on the patients and something like that.
You mean variability in the type of error or the region? The region, so the anatomical part, or I mean both. Yeah, they're not mentioning that. Now to think of it, variability does not, I mean, I could control F now. I don't have it in mind that it was mentioned a lot in the paper. I agree that would be a really informative figure as well to see how much, how clear cut any of this is and how much there is variability in overlap of maybe there's still a region where a lot of errors just mix in its quality. And what does that tell us? But no, it's not mentioned. Okay. There are other papers looking into this, but this one did not do that.
Okay.
And from my own experience, we do find that. Unfortunately, it's not as nicely that per patient you find all of your phonemic errors on the endpoints of the EAF and all your semantic errors in the temporal lobe. So this would have been really helpful indeed.
Okay.
But it's not available.
Lilith, final question.
Yeah, thank you. Thank you for sharing this paper. It was really interesting. The thing that I mean, for me, it was interesting the fact that low-grade gliomas and high-grade gliomas, they're like showing different results. First, I want to ask, the low and high-grade means the stage of the tumor or different type of the tumor?
The second. So, I mean, they all go hand in hand due to the fact that if it's a high grade, it's often so fast growing that it's often found at a later stage already. But the definition comes from which kind of cells it stems from. So the high grade are often so-called glioblastoma, and multiform. So they spread like crazy and very fast. So that's where it stems from.
But do they discuss something about why it is different?
So just by the fact how slowly it, like a low-grade glioma can grow over 10 years, which allows the brain to compensate a lot. And maybe still assume a lot of its, relocate some of its function. Whereas in a high grade, a lot of what, from my point of view, I think a lot of the processes, the normal processes are already broken down. So I consider them a much more fragile group when it comes to stimulation, because they already have quite some symptoms of aphasia as well. So from my point of view, they're all just, the entire language has deteriorated much more. And then mapping, you need to fall back to different tasks given their status, so behaviorally, but as they show here also neuroanatomically.
So can we say that behaviorally, the high-grade patients with high-grade tumors, they are more close to acute stage of stroke? Or
yeah, in very crude definition, yes. Also what from what I've seen in low grade, if you don't take really fine-grained linguistic tests, you might not notice any speech or language deterioration. Whereas in low grade, they sound close to normal, and high grade, they come already with word finding problems, apraxia of speech. So yeah, closer to what you're used from the stroke population.
Yeah. Thank you so much.
Also, just to follow this up, so the impact on the anatomy is quite different, right? If you have a slow-growing tumor, it's likely to push away the brain tissue, gray and white for that matter. So it kind of displaces the anatomy very slowly, and the brain also has time to functionally adjust to a certain degree. Whereas when it's a fast-growing mass, then it's more likely to infiltrate and disconnect certain parts of the brain, and the brain doesn't have the time to adjust to those changes as well as it can with a slower disease progression.
Yeah, particularly the right hemisphere. So in this low-grade group, there are papers showing how much the right then slowly but surely takes over, versus the high-grade group, there's no time for this to happen.
Thank you.
Thanks for the questions.
Great. Thanks for presenting this amazing paper. Super interesting. And we've definitely been waiting for an overview like this for a long time. So I'm very happy to see this paper out.
And just a final remark, apparently this is not only the only review they did, it just was exceeding the scope. So the same group has a second paper diving more into this when it comes to postoperative outcome. They mentioned this later. So I think we might be able to expect more out of this pool of data for more papers.
Fantastic.
Maybe answering some of our questions that we now have.
Yes, finally getting there. Thank you so much for presenting the paper and for joining us for Neuroccino for the first time. See you all next week. Have an exciting week in science. Bye.
Bye.
Bye.